speaking on a common topic, dislocated lens and dislocated nucleus. I just want to know how many of you still put scleral fixated, how many put AC lenses, how many put glued lenses, and how many put sutured with Gore-Tex? None. I think we have Pramod who does it. I had a discussion with Pramod about 10 years back. I think it was a Gulmarg we were discussing.
Yes, yeah.
And we were discussing retrospective analysis of subluxated, scleral fixated IOLs. And that time we felt that 10-0 suture it will not hold. This is about 2009-10 we discussed.
Yeah.
And he's done one of the maximum scleral fixated and he still holds on. And I was discussing with him, he does Gore-Tex suture. So Gore-Tex 4-point fixation. If you use the American Academy website, they have these Gore-Tex suture videos on it. So there's a patient, one of my fellows is doing, it's a subluxated IOL. And planning a scleral fixated. So still the jury is not out which lens is ideal for a subluxated nucleus. Is it an AC? Is it a scleral fixated or a glued? There are no comparative studies and none published data. Though we have so many workshops on glued, we have no published data of long-term follow-up of glued edge. Now you have a new Yamani technique where you just cauterize the edge. So here's a patient with almost 360-degree dialysis, and for a retinal surgeon it's easier to actually dislocate and remove it than trying to do it in the anterior chamber. So once you, there's nothing much in the surgery, it's just that a lot of anterior segment surgeon, if they are there, would like to first try iris hooks, use lens hooks, put a CTR, put a Sionis. But for a retinal surgeon, doing a subluxation and then creating putting a scleral fixated or a AC lens is much easier. And this is a technique I think which has been done for tens of years. The scleral fixated one. The only issue is that scleral fixated can have a pseudo phacodonosis. So now there's a 4-point fixation coming up using Gore-Tex sutures, 7-0 sutures. Gore-Tex sutures was initially used for ptosis actually about 10-15 years back, and it's supposed to be less biodegradable than the 8-0. Now we all use 8-0 proline if we have to do a scleral fixated. The problem is that if you have a high myope or Marfan's, the chance of doing a glued IOL is difficult because the sclera is thin and long term you can have a scleral necrosis. So some of us still prefer scleral fixated in a thin sclera than doing a glued IOL. I still do a lot of my patients with AC lens if the AC is deep, and I find the results are pretty good if your vitreous management has been good in this. This is a standard technique just for discussion. I put it out as scleral fixated is still there. So one of the Sanjeev Hasranj has been kind enough to give me a retro fixation of the iris. This is the retro fixation of the iris clip. This is Sanjeev's video. He uses a lot of iris claw lenses retro fixation. So this is the removal. Generally, if you tend to sometimes pick up, you don't have a end gripping force. You try to pick up with the ILM forceps, the lens tend to get a slip. Use a wide flatter to forceps to pick up the lens. Suture it, and here's a retro fixation. So we have this option of putting an AC lens, which everybody knows how to put it, scleral fixated. But remember that when you're doing a vitrectomy and you're putting an AC lens, you have to almost switch off the infusion because the iris tends to come out when you're putting an AC lens. And if it's infusion is on, you tend to have a pupillary block. So you have to do a PI also with the infusion almost stopped. In this, basically you're going to clip the iris into the defect, the cut part of the iris claw. So my aim of showing was that still that there is a controversy which lens, which sutures to use, but all options are equally good as long as it's good in your hands. And this is a The majority of the phaco machines have a 20 gauge phacofragmentome, while the DOC gives you a 23 gauge phacofragmentome. This is a 23 gauge phacofragmentome being done using a DOC machine. That is the advantage. Other all give you a 20 gauge probe with the phaco, which you have to take out the trocar and then do the phacofragmentation. This is just standard surgery. But now with the experience of the new generation, less and less subluxated lenses are coming, and maybe the surgeons are removing the IOL. What Dr. Pramod showed, what happened 10 years back, may not be a regular event these days. So you, in a subluxated nucleus, the area where you were doing the enter the frag, the vitreous needs to be cut extensively, otherwise you create a tear. You remove the nucleus before you generally create a PVD, so, and then create the PVD. And if you have a soft one, the problem with it is that since they enter 23 gauge, very hard ones, you can't actually chop inside. You have to, initially we should use almost like a 20 gauge chopper to chop the grade 5. And now you generally difficult in a more in 23 and a 25 gauge. Doing that a grade 5 is slightly more difficult until you engage in a pick. I think we leave more for discussion and ask the other panelists what they are doing. Dr. Pramod would like to share your experience of Gore-Tex sutures. Which company is giving you the Gore-Tex suture?
Company name I do not remember offhand. I'll check and then show you if necessary. I'll check and let you know. But basically it's a 7-0, quite a thick suture.
Yeah.
And the needle is very, very thick. Really difficult to use. So we have to keep on constantly modifying now. So what I do now is, yes, I still use 7-0, but I pass the suture through the haptic and then chop up both the ends and leaving those loose ends through the haptic eyelet, and then the bed which already made. So I use 25 gauge trocar cannula system, straight enter through that. So within the bed there are two, you go through, then your 25 gauge forceps goes through that, come through the limbal section, hold the suture and come out. I can show the videos there, and I'll just, time is there, then
that will be interesting, something new.
Yeah. So
I think Puneet can give his lecture, then we can have Dr. Pramod.
yeah, Puneet finish, and then I'll just, that's I think some 48 second, I mean, this is a very concise video, I'll just go through that way.